Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in.
Welcome. My name is Paige. We're going to be going over sepsis today. Sepsis is a really big, broad topic, and there's a lot of different parts that you have to understand in order to get to a place of complete understanding of the physiology of sepsis. So we're going to be talking about a lot of different things today. Sepsis is a state of shock that your body goes in, and so we need to go over all of the different kinds of shock. It'll just be a quick review. We'll go over the definition of sepsis and the immune response, inflammation. Then we're going to spend a lot of time talking about this idea of the sepsis waterfall, which leads to SIRS, MODS, and then some treatment. Once you understand all of it, then you'll understand what to do in the field. So there's 4 different kinds of shock that we're going to go over: hypovolemic, cardiogenic, obstructive, and distributive shock. So what is shock? So by definition, it is a life-threatening clinical state characterized by body-wide deficiency of blood supply. So that can happen in all sorts of different ways, and that's why it's categorized into several different kinds of shock. There are several causes, including cardiac conditions that can lead to body-wide deficiency of blood supply. Obviously, a severe hemorrhage, if you have a big open wound, you're not going to be able to get blood around your body as it needs to. Spinal injury, infection, which is what we're going to spend most of our time talking about, and of course, anaphylaxis. The main symptom of any type of shock is hypotension. So you're not really technically in a state of shock until your body is unable to get the blood around the system enough that your blood pressure drops. So if you have severe hemorrhage and you would be in shock once your blood pressure is low, you would be in cardiogenic shock once your blood pressure is low, if that makes sense. And the treatment obviously depends on what type of shock the patient is in. So fixing a cardiac condition is not going to work if you have a giant wound on your leg. So obviously that makes sense. So the first type we'll talk about is hypovolemic shock. This is probably the easiest one to understand. So this is a pretty small amount of the shock patients that you're going to see. It's only 16%. It occurs when the circulatory blood volume is severely reduced. So the most obvious one that you can think of is an external blood loss. So a GSW, an open fracture. You are losing blood outside of the body because of some sort of injury. The second one is internal blood loss. So think of like internal bleeding. When you have a patient who's in a pretty bad NVC, they don't look that bad from the outside, but when you start treating them, you're seeing that their heart rate is super high. They're having some maybe distension around their abdomen, and then eventually their blood pressure drops. That's probably because they lacerated something inside of their abdomen. So that's the second type of blood loss that you can have that's not coming outside of the body, but you're still losing it inside of your vessels. And the third kind is fluid loss. So a lot of people don't realize this, but you can go into hypovolemic shock from too much vomiting, too much diarrhea, definitely from major burns. You're losing a lot of your fluid. DKA is definitely one. But if you are losing a bunch of your fluid, your blood volume is going to decrease and you're not going to be able to circulate it as well. So you can definitely, that's why when you get the flu, the stomach flu or something, they encourage you to drink lots of water to counteract some of the vomiting and diarrhea that you're experiencing, because you don't want to go into hypovolemic shock. Cardiogenic shock. So this is also 16% of shock patients. So this is a problem with your pump. So a problem with your heart, and think of that as the big pump around your body. So this occurs when that big pump does not work properly. So it fails to pump sufficiently. It can't get the blood around the body. And so it kind of goes into a state of failure. So this can be caused by various arrhythmias. So I want you to think of someone whose heart is beating too fast, or maybe their heart is beating too slow. And so their heart is not working sufficiently to get that blood around. It's not beating hard enough and fast enough, and so the blood kind of gets stagnant, or it's beating too hard, and so it doesn't have time to circulate the blood. Obviously, there's also like arrhythmias that are not conducive with life. So you can have someone in VFib, VTAC without a pulse, PEA. Those are all arrhythmias that our heart can get into that the patient would die if they remain in those. You can definitely have cardiogenic shock from myocardial infarction. So an MI is, in lay terms, a heart attack. So there's some sort of blockage and death to part of the heart, and so it's not able to circulate that blood. So we see definitely a lot of people in cardiogenic shock secondary to an MI. And there's not a lot that we can do in the field other than get them to the hospital so that they can have that clot removed so that the blood can then recirculate. And then you can definitely get cardiogenic shock, end-stage cardiomyopathy, CHF, myocarditis. Anything that can affect how well that heart is pumping can lead to an insufficient blood flow and then lead to cardiogenic shock. Obstructive shock, this one's super rare. 2% of all shock patients. This one's a little bit harder to understand. It's caused by an obstruction of blood flow and a major circulatory component. So I want you to think of your aorta or maybe your superior vena cava, a huge vessel in your body that for some reason has an obstruction in it, or something is pushing on it, causing the diameter of that vessel to decrease. So you're not able to move a ton of blood through some sort of major circulatory component. So things that can cause that is a tension pneumothorax. So you're getting an increase in inner thoracic pressure, pushing on that aorta, pushing on that superior vena cava, not able to get the blood to and from the heart. Cardiac tamponade, again, the heart isn't able to really pump that well, and so you're having a major circulatory component. The most major is the heart, so you're not able to push blood through. Pulmonary embolism, so there's lots of vessels in our lungs. If you get a huge clot up there, you're not able to circulate through and get the oxygen that your body needs. And then an aortic aneurysm, so damage to the aorta. These are all things that can cause obstructive shock. And remember, you're going to know that a patient is in obstructive shock or any state of shock when their blood pressure begins to drop. So this is the one that we're going to talk about the most, distributive shock. So this is definitely your most common type of shock that you're going to see in the field. So more than half of all of our patients that are in shock are in distributive shock, so 66%. So this occurs when excessive vasodilation drops the blood pressure too low to circulate that blood. So vasodilation means that your blood vessels are dilating too much. And so there's not enough pressure to push that blood back up to the heart. So it kind of just sits down in your capillary beds or in your vessels. Distribution-related shock is broken up into 3 categories. So septic shock is our most common. We're definitely going to spend a lot of time on that. Anaphylactic shock and neurogenic shock. So that's caused by central nervous system damage. Essentially, all of those cause widespread vasodilation. A lot of people think that people die from anaphylaxis because they can't breathe. People definitely do, but really what puts the patient into anaphylactic shock is this widespread vasodilation, and so the blood just permeates and sits in your capillary beds down in your feet and your hands, and so your heart isn't able to pump. Same thing with neurogenic shock. Your brain stops sending signals down when there's some sort of injury to your spinal cord, and so your vessels stop putting any pressure on that blood. And we're going to talk pretty extensively about how this happens in sepsis, why it happens in sepsis, and how you can prevent someone from going from maybe a systemic inflammatory response to septic shock. The problem is the distribution of blood volume, right? That's kind of what we were talking about. The blood sits in those capillary beds. In a non-septic distributive shock, they're going to be tachycardic. So you're going to see that a lot with anaphylaxis. Their heart rate's going to be super high. But if you're seeing a normal heart rate or maybe a low heart rate, you're probably looking at neurogenic distributive shock. Septic shock is 93% of the distributive shock patients that you're going to see, or 62% of all shock patients. So it's very common to see someone in septic shock. You diagnose this in the field with a method called QSOFA. We'll go over that in a little bit. But the difference, again, between just being septic and being in septic shock is that hypotension, right? So you have a requirement of vasopressors, which is a drug that increases a patient's blood pressure. So you require those in order to maintain normal blood pressure, and you have a lactate of more than 2. So that's just a lab value that the hospital will run, and it just says that your lactate is more than a normal person's lactate level would be. So septic shock, the body is overwhelmed by a systemic infection. So the body attempts to regulate this infection with a waterfall release of cytokine, which we're going to go over, which ultimately leads to vasodilation and cellular fluid shift. So I want you to think of, it's kind of easier, at least in my brain, to think of septic shock. So compare it to an allergic reaction. So lots of people can have an allergic reaction, right? You get stung by a bee on your forearm, you get a little bit of a swollen thing where the stinger is sitting, and then that's it. So that's the very, very basic, right? So your body is sending cytokine over to that spot where you got stung. It's creating a little bit of swelling. It's trying to get rid of the venom from that bee sting. And then once it's done, then it's done. But then you can also have, maybe you get widespread hives everywhere. So that's a little bit more of an allergic reaction that your body is sending. It's saying, there's something in here that I don't like, and I don't know where it's at, or I don't understand how to fight it, so I'm just going to fight everything. And so it's sending inflammation widespread around the body. Then you can have anaphylactic shock. So that's your body really, really overreacting to maybe a bee sting. So it knows that it's stung by a bee. It's kind of freaking out. And so it's saying, I'm just going to shut down completely because I don't want that venom to circulate around my body. So I'm just going to vasodilate. I'm going to have hives everywhere. I'm going to have widespread inflammation. And so that's a big overreaction to a small thing. So that's kind of what septic shock and sepsis is. There's some sort of infection, and your body goes from just sending white blood cells to kill that bacteria or that infection, and then it starts to overcompensate. So it starts to have widespread inflammation, have widespread vasodilation and permeability and that fluid shift. So it's a big overreaction to an infection in the body. So sepsis is a spectrum. Their symptoms will help diagnose where they fall on that spectrum. So you can have SIRS, which is kind of like the equivalent of just that little bit of inflammation from your bee sting. So your body is saying, there's something in here I don't like. I'm going to send some white blood cells, a little bit of inflammation over there, try to kill it. Then you can have sepsis, which is it's sending those signals all around the body. Septic shock is when your body is like, I don't know what to do, so I'm just going to vasodilate. And then MODS is like your final, how people die from septic shock. So you have widespread damage to your organs because they're not getting the oxygen that they need. Most patients that die from septic shock ultimately die from sepsis-induced ARDS as a result of MODS. So we're going to go over what all of those abbreviations mean, what ARDS is, and how it can kill you. In order to understand the body's inflammation and the body's response to infection, you have to understand immunity. So immunity is the physiological process that provides an individual with protection or defense from disease. So you have white blood cells, different kinds of cells in your body that their entire purpose in life is to fight any substance that's deemed foreign. So we have a systemic collaboration of cells, tissues, and organs working to protect against these invaders of the body. So our 3 main protective functions: we protect from invasion, we remove dead or damaged tissues and cells, and then we remove mutating cells. So there's three kind of ways that your body can have some sort of immune response, and those are the three ways. So you can get immunity when you're born. So that's kind of your innate immunity. You have it from the time that you're born, you get it from your birth mother, and it provides non-specific protection. So it's kind of just like your body's very first kind of like, hey, we have guns and knives and we're going to go kill any of the bad bacteria, but we don't really know what we're fighting yet. Acquired immunity, that is where your body learns from things that it's exposed to. So you come into contact with the flu, and your body is going to learn the shape and the response that it gets from the flu, and it's going to learn how to fight that very specifically. So that's acquired immunity that you gain from the environment around you. So you can get passive antibodies from someone. So if I get a transfusion of blood from someone, then they have those very specific acquired immune cells, right? So things that they've been exposed to in their lifetime, and I'm now getting their blood. And so I'm getting some of those immune cells myself. Breastfeeding, so you can get some immune cells from your mom. She's passively passing you as an infant. Then you can have an active immunity. And so this develops in response to foreign antigens. So a really common one is a vaccine or an immunization. So it gives you a very small amount of dead bacteria, a dead foreign body, and your body goes to fight it. It learns how to fight it well. And then if you ever were to come into contact again, your body already knows how to fight it. So those are the kind of different ways that you can gain immunity from either birth or from the environment. So we have different lines of defense with our immune response in our body. Obviously, our very first line is our physical barrier. So there's tons and tons and tons of bacteria and viruses in the world, in our environment. And obviously, we don't walk around being super ill all the time. And that's very much to thank from our physical barrier. So our biggest one is our skin, right? So things aren't getting directly into our bloodstream because we have a giant skin protection. Microbial flora, stomach acid, mucus of the respiratory tract. So think like snot and saliva. You have microbial flora in your digestive system, in your, like women have it in their vaginal canal. All of these things help protect you from getting things from the environment into your bloodstream. Then we have non-specific immunity. Remember, this is kind of what you're born with. So your body knows how to do inflammation. It has white blood cells that eat dead things, that kind of fight non-specific things. And there's just part of your body. And then the acquired immunity. So these are specific fighter cells that know exactly what they're going after. And those are called antibodies. So you have several different lines of defense before your body kind of succumbs to an infection. So you have a range of immunity. Most sit in a normal level of immunity. So just as long as you are not a brand newborn, so you don't have those acquired antibodies yet, or you're not taking immunosuppressants or something, then you're sitting in that normal range. Suppressed, so this is going to be maybe like super elderly people, brand new babies, people that don't have the ability to use the antibodies in their body. And then an exaggerated immune system. So these are going to be people who have an autoimmune disorder. So that's kind of the body attacking itself. It has a very exaggerated response. Allergic reactions is a temporary state of exaggerated immune response, kind of like what we talked about. And also septic and sepsis and septic shock. That's a state of exaggerated immune response. So inflammation, remember, this is kind of our second line of defense in an immune response, an immunologic defense against tissue injury, infection, or allergy. So the purpose is to remove harmful stimuli and begin repair. So that's why inflammation, remember, that's just like an influx of cells, red blood cells, oxygen, like things that fight. So white blood cells, antibodies, it's just pulling things into that specific area, and it causes a little bit of inflammation. They do that so that it can begin to repair whatever's happening. So if you get a cut on your leg it can get a little bit swollen, right? Or if you twist your ankle and it gets a little bit swollen, and the purpose is to repair those broken tissues. So you can be in a state of acute, chronic, or restorative inflammation, and that inflammation can either be systemic or localized. So, an acute inflammatory response, this is when your body is saying, there's something wrong and I need to send cells down to create inflammation somewhere. So, tissue injuries. So, you could have a big cut on your leg, you can have a sprained ankle, you can have maybe a staph infection, something like that. But an injury to that tissue causes a release of chemical messengers, and we'll go over kind of what that means, to draw other cells to help fight off that pathogen or that injury, right? So there's your white blood cells release what's called cytokine. And I want you to think of cytokine as kind of like a flare. So a blood cell, let's talk specifically about an infection. So a white blood cell comes into contact with something that it's saying is bacteria, something that's dangerous to the body. So it comes into contact with it, it sends off a flare, and that other white blood cells see that flare and they come help. So it's kind of like an SOS call. So the blood vessels around wherever that SOS call was dilate to make room for those extra white blood cells to come. And the blood flow to that affected area increases. And that makes sense, right? How do we get red blood cells, white blood cells around the body? As a blood flow. So you can't just send white blood cells. They don't walk on their own. They have to go in the circulatory system. So the blood flow increases to get all of those helper cells to come. And then that vessel dilates to make room. The endothelial cells, so this is the cells that make up the blood vessel. So the blood vessel itself partially retracts. So that causes little tiny holes in that vessel wall in order to increase permeability. And the purpose of that is so that it can get more oxygen, that extra fluid can have a place to go. But if it happens long term, obviously it causes problems. Water, salts, fibrinogen, and proteins move from the intravascular space into the tissues. So it's just kind of saying, we don't need you right now. We need red blood cells and white blood cells to come. So you guys move out, other things move in. That affected area is blocked off to delay the spread of the pathogen. And some of that leaky vessel is so that you get a buildup of that extra cellular fluid. So fluid that's outside of your vessel that kind of pinches down on either side of that vessel to make sure that you're not spreading whatever this bacteria that caused that big SOS call, so that you're not spreading it around the body. Phagocytes and specific immunity cells move out to begin acting on the pathogen. So they kind of have like a rally call, and they move in and they begin trying to fight it and then eat it. And then tissue healing occurs as space left by the damaged tissue is filled. So a normal inflammatory response to an infection. That's how the body fights it off. I know that's a lot of specific pictures in your head that you have to kind of follow along. But I just think of a big SOS call, lots of different cells come in to help. And the idea is so that you don't start spreading it around to other parts of the body. So kind of a big overview, chemical signals released. So that's that cytokine or that big flare SOS call. This causes vasodilation and increased capillary permeability to make room for those extra white blood cells. Fluid, antimicrobial proteins, and clotting elements moved into the affected areas, and the clotting begins. So that's other things that come in to make it so that we don't spread it around the body. Chemical messengers signal more phagocytic cells. So that's kind of secondary SOS calls saying we've killed it, now we need something to eat it. Then pathogens and cellular debris are consumed and tissue healing begins. So those phagocytes come in, eat the damaged parts of the cells. The tissue healing begins after that. So sepsis waterfall. So this is what happens when you have your body is starting to do all of those steps, but it's happening all over the body. So the bacteria virus makes contact with a white blood cell. That white blood cell sends that cytokine, so it releases that SOS call. The vessels dilate to make room for the influx. Endothelial cells pull apart, creating a leaky vessel wall. Intravascular fluids move to that third space in order to make room for those white blood cells. White blood cells release enzymes that damage the vessel and cell walls. So this is kind of an important piece. So white blood cells are trying to eat and fight off the bacteria, but sometimes they start to damage the vessel itself. So it's releasing these little things that eat and take apart the bad stuff, but it also starts to eat and take apart the good stuff. So you're starting to get injury to the wall and injury to red blood cells and kind of the musculature around wherever that infection is. So in response to that, the body produces coagulation factors to heal those vessel walls. So it's sending in things that build blood vessels and clots. So it's saying, I have an injury on this cell wall down in the leg, and I'm beginning to bleed. So now I need to send something in order to stop that bleeding. So you get extra coagulation factors resulting in excessive thrombosis. So you're getting a little bit too much of those clots when you're in kind of a sepsis waterfall. So remember, the difference between just a regular infection and sepsis is that sepsis is body-wide. So this is happening everywhere in your body instead of just one single spot. So this is no longer going to be healthy, right? So you're breaking apart vessels all over the body. Your body is attempting to send coagulation factors all over the body. And so it's kind of beginning this idea of overreaction. And so you're going to get a lot of these clots that are on these walls that are going to start breaking off. Because one, maybe they just weren't quite big enough because they didn't get enough of that coagulation factor, or they're too big. And so then they kind of break off from that vessel. So that vessel begins bleeding again, and you have this clot that's now traveling around the body. And so then the body attempts to send more coagulation factor to fix that bleeding because that clot broke off. And so eventually the body runs out of coagulation factors. And so you're in a state of both having too many clots going around the body, and you're in a spot where your body's bleeding and we don't have anything to control that. And so your body enters into what's called DIC. You hear DIC a lot, maybe when you're talking about if she's having postpartum hemorrhage, she goes into a state of DIC. So DIC is disseminated intravascular coagulation, and essentially it's that you're bleeding and also have too many clots going around the body, and there's just no coagulation factors left in order to heal it. So you're beginning to get damage to vessels all around the body. You don't have anything left, so there's lots of bleeding happening around the body. And that's not just your vessels that feed to your muscles, it's also vessels that lead to your organs and into your lungs. So a very, very common reason of death from sepsis is ARDS. So this is the damage to the vessels in the lungs lead to an increased fluid buildup in alveoli and decreased gas exchange. So ARDS is acute respiratory distress syndrome, and it is a devastating complication of severe sepsis, and it has a very, very high mortality rate. And we're going to talk specifically about ARDS in a little bit. But you get this idea of DIC combined with ARDS, combined with damage to vessels and organ walls, and this results in what's called MODS, or multiple organ dysfunction syndrome, MODS. So this is happening all over the body. It's beginning to attack things like your kidneys, your liver, your stomach wall. This damage to the vessels is happening everywhere, and so you're going to get multiple organs beginning to fail, combined with the fact that you're bleeding everywhere, combined with the fact that your lungs aren't working correctly. And this is how people end up dying from septic shock. I know that that's a big, broad explanation of what happens with sepsis, but you have to remember that this happens in stages. So you go from just a simple inflammatory response to body wide. So SIRS is kind of the secondary step. So this inflammation occurs in body sites and organs remote from the initial insult. So essentially you have some sort of infection, maybe a skin infection, but you're starting to see some inflammation also in the liver or near it or in other body sites other than wherever that skin infection is. So the common causes of this is tissue trauma. So you definitely see this in burns, sometimes in surgery, crush injuries. You're seeing damage in other parts of the body. Abscess formation, ischemia or tissue necrosis, obviously a microbial invasion, endotoxin release. So you can get either gram-negative or positive bacteria. Systemic hypoperfusion. So think about someone who's achieved ROSC or is in some sort of other kind of shock. They can go into a systemic inflammatory response or a localized hypoperfusion. When someone is in kind of this secondary state before they reach a point of sepsis, the focus is on reducing inflammation. So heat and cold is sometimes what we'll do. Managing their fever, because that's kind of the body having an inflammatory response. It's working in overdrive. So we need to keep that fever down. And then providing pain relief. So this is someone who's sick. So you can have a person with SIRS who has a UTI. That's a really good example. So the infection is in their urinary tract, but you're seeing a fever, you're seeing some pain. So you're just managing their symptoms. So then the third step after SIRS is sepsis. And this is when it begins to go body wide. So life-threatening organ dysfunction caused by dysregulated host response to the infection. And then the last stage kind of is septic shock, which leads to ARDS and MODS. It's a subset of sepsis with circulatory and cellular metabolic dysfunction associated with a higher risk of mortality. So worldwide, a quarter of the people who are diagnosed with sepsis or septic shock will eventually die. That's huge. So that's over 1.5 million patients every year in the US. That's a very, very large number. 250,000 deaths. 1 in 3 patients who die in the hospital have sepsis. So think of all the reasons that people go to the hospital and that the reasons that they die. 1 in 3 are dying from sepsis. So either we just don't understand enough and we don't have the ability to stop that sepsis waterfall before it becomes too much. And a lot of the time, in up to 30% of the cases, we don't even know what the patient is suffering this sepsis waterfall from. So we don't even identify a specific pathogen that started the entire waterfall to begin with. So we diagnose sepsis with a couple different ways, but a very common way is this idea of Q-SOFA. So this is a way that we grade someone's level of infection outside of the hospital. So us as medics and EMTs come into contact with people who call for maybe a UTI or they call for a fever. And when we get there, we are suspecting that maybe they're starting the first couple signs of the sepsis waterfall. So obviously, someone's not going to go into a sepsis waterfall because they twisted their ankle, right? That's just going to be an inflammatory response. And that's completely different than someone with a suspected infection that then goes into an inflammatory response. So the very first thing, obviously, that we need to have if we're going to consider that maybe someone has sepsis is they have some sort of a suspected infection. So maybe they had recent surgery. Maybe they're having difficulty urinating. Maybe they were in the hospital a couple weeks ago, or they have like a junky cough. They have a fever of some sort. That's telling us that maybe there's an infection somewhere in the body. And then Q-SOFA. So this is a way that we measure people's symptoms. So in order to meet Q-SOFA criteria, they have to have 2 or more of the following. So they have to have a fever of above 100.3, a respiratory rate of more than 22 per minute, a heart rate above 100 beats per minute, a systolic blood pressure of less than 100 systolic, and an altered mental status. So a Glasgow Coma scale of equal to or less than 14. And then there's other things in the hospital that they're going to look at their lactate levels, their white blood cell levels, and definitely something that paramedics use is someone's end tidal value. So it kind of correlates with this high respiratory rate. So if you're counting their respiratory rate and they're breathing like 30 times a minute, you're going to expect that their end tidal is going to be low, right? So a lot of paramedics will place what's called an end tidal nasal cannula on a patient who they believe might have some sort of infection. So it's usually green, but it goes on their nose. They plug it into the monitor, and the monitor spits back a number. And so if their number is below 25, then that's another signal to a paramedic or an EMT that maybe this patient is septic. So let's say we go on a patient, Mary. Let's call her Mary. Mary has had a low-grade fever for 2 days, and now she's beginning to feel weak, and the daughter called because she's kind of acting funny. So you get there, they say that they've been giving her some Tylenol for the fever. They thought maybe she had a cold, and when you talk to her, she responds to you, but she kind of trails off. You ask her what year it is, and she says, I don't know. And you ask her the president, and she kind of laughs, and then she can't find her words. So that's telling you that maybe she's not a GCS of 15. Let's put her at a 14. You take her temperature, it's 101.2. So that's meeting another criteria. And you put her, so you're like, okay, let's go to the hospital, Mary. You put her in the back of the ambulance. You stick her on the cardiac monitor. Her heart rate is 120. Her blood pressure is still okay, about 105, but your partner puts on an end tidal nasal cannula and it says it's 21. So that's meeting 2 or more of the QSOFA criteria. And when you put that nasal cannula on, it also tells you how many times a minute she's breathing. And that number is 28. So that's above 22. So that would be signal to that paramedic that this patient is septic. And so a lot of agencies around the United States now have what's called a sepsis alert. And they've created this idea that if a patient meets QSOFA in the field, then they deserve a fast response, so lights and sirens to the hospital. And the hospital is going to start very aggressively treating for an infection because they're trying to stop sepsis waterfall before it gets out of control. So these are all kind of things that you might think of if you're suspecting an infection. So pneumonia, urinary tract infection, acute abdominal infection, meningitis. That's a very common one that people forget about. Soft skin tissue infection. So like something as simple as cellulitis can lead to sepsis. Bone, joint infection, some sort of wound, obviously. If they have a catheter of some sort, even a PICC line, a urinary catheter, an IV, that can be a source of infection. Endocarditis, implantable device infection. So if they have maybe an internal defibrillator and you look and it's kind of red around that site, those are all things that can maybe lead to a source of infection. So we kind of talked about QSOFA, but the big major ones is the elevated respiratory rate, a Glasgow Coma scale. It depends on which part of the country. It's either 14 or 13, depending. But so they just have an altered mental status, and something that tells you that they're in septic shock, remember, is a systolic blood pressure of 90 or below. So they can have sepsis without septic shock. So Mary was septic, but she wasn't in shock yet, remember, because her blood pressure was above 100 systolic. But if they're below 90, then you're dealing with further advancement in septic shock. Suspected infection and 2 or more criteria should initiate sepsis care and coordination. So that kind of going to the hospital quickly and the hospital aggressively treating, getting antibiotics on board. That's all attempt to stop that sepsis waterfall. This is talking about that end tidal nasal cannula, and we talked about why increased respiratory rate would lead to a low end tidal. But if the patient is so far down that sepsis waterfall, the patient is no longer able to compensate with that increased respiratory rate. They'll start breathing slower because of that ARDS, and then their end tidal will begin to rise. So, the stages of septic shock, the initial stage is that drop in blood pressure. Then they shift in metabolism from aerobic to anaerobic, attempting to hold on to that extra oxygen. So, it's metabolizing without that oxygen. They have decreased oxygen levels, and the liver is unable to remove lactic acid. So, you're going to get a spike in that CO2 with a decrease in that oxygen. And the clinical signs at this point, like at the very, very end, they're not going to have a high heart rate. It's going to begin to drop because their cardiac output is dropping. They're going to be breathing slower. So, a lot of the things that you would suspect in that early stage when you're looking at QSOFA, even like a fever, they're going to start losing that ability. So, they're going to go what's called cold septic. So, their temperature is going to drop. So the clinical signs are not usually manifested in the very, very late stages of septic shock. So we have compensatory stages. So this is the very beginning. The body attempts to overcome that anaerobic metabolism, seeking homeostasis. So it's going to change the level of consciousness because it's not sending as much oxygen to the brain, hypotension. Obviously, we talked about why that happens. You're going to have a ventilation perfusion mismatch. So that's definitely like a paramedic level idea, but something that signals that you're still in that compensatory stage. Decreased GI motility, so it's sending blood and oxygen to things that are important, and so digestion is not at the very top. The skin becomes cool and clammy. So if someone's all the way in septic shock, it's usually warm, flushed, they have a fever. But if they're cool and clammy, they're still in that compensatory stage. Decreased renal flow. Then they reach the progressive stage. So this is kind of where it gets really dangerous. So their compensatory mechanisms begin to fail. The decreased cerebral perfusion pressure causes altered mental status. The cardiovascular system, you start getting that edema because of the capillary permeability, and that damage to those vessels has that extracellular fluid shift. Their blood pressure decreases, obviously, and that is showing that they're in septic shock. Heart rate increases to compensate, but then eventually will decrease, and then their overall decrease in myocardial perfusion. Respiratory, you're going to get pulmonary vasoconstriction and increased capillary permeability causes edema and diffuse infiltrates. So you can start to get like buildup in the lungs and difficulty breathing. Surfactant decreases, alveoli collapse, and shunt worsens. So this is kind of how you get into ARDS. Decreased compliance with bronchoconstriction and increased heart rate because they're not getting the oxygen that they need. And if not corrected, it will may progress to acute respiratory distress syndrome. Gastrointestinal system, you have ischemia, increases risk of ulcers, bleeding, and bacterial migration to the blood, decreased nutrient absorption. So this is kind of like your long-term sepsis patients. The renal system, acute tubular necrosis may lead to acute kidney injury. So that's how you're beginning to head towards multiple organ dysfunction. Drugs such as antibiotics may exacerbate that problem, and the kidneys unable to excrete acids, leading to metabolic acidosis. So these are really, really broad, huge ideas, but essentially, when your body is in a state of anaerobic shock, all around the body is being affected. The liver is not able to excrete drugs and waste, decreased ability to function immunologically. You're not getting that immune response that you need because you've been doing this huge immune response for a long time. Hematologic, so that's your blood system. Your platelets and clotting factors are used up in creating extensive microclots. So essentially that idea of that DIC that we talked about. And we need to have rapid and aggressive treatment in order to keep this from developing into MODS and ARDS, because when we hit those stages, it's very, very high mortality rate. Refractory shock. So you would see this in the field with a low blood pressure that you can't get their blood pressure to come up with some fluids. So organs begin to fail. You have failure of one organ that causes failure of multiple organs. So you get that MODS response. Decreased perfusion continues to aggravate anaerobic metabolism. And then eventually this all leads to death of the patient. So a quick review of ARDS. So this is acute respiratory distress syndrome secondary to sepsis, right? So it's a sudden onset and distinct progression, and you have those white blood cells attempting to eat away at that bacteria body wide, including the lungs. It's creating holes in the vessel walls of the lungs. So you have that fluid leak from the interstitial space into the alveoli. So you aren't able to open up that alveoli to get your oxygen and CO2 exchange. So you get atelectasis, reduced compliances with breathing, the vent, something like that. And fibrosis occurs if progression continues. Aggressive management and ventilation is required when someone reaches the state of ARDS. So you can see in this picture, the left lung is completely full of fluid and the right lung is not. So you just aren't able to exchange oxygen the way that you need to. And so that decreased oxygen begins causing a bunch of organs to fail. So multiple organ dysfunction. So this is caused by SIRS. It's not separate stages from septic shock, right? This is a continuum. So it just keeps happening. It's a waterfall of events that one signals the next, signals the next. Inflammation in immune systems activate hypotension, decreased perfusion, shunting to the middle of the body, hypermetabolism, the clotting cascade. So you get that DIC, organ failure, which is your MODS, and then death. That was a lot of information about how sepsis is just catastrophic to our body and how you can have little reactions to some sort of bacteria. You can have a skin infection that just remains a skin infection, especially in healthy people. But if left untreated, right, you don't go seek care. So you begin developing a fever. If you're older, you begin to have that ultramental status. You can see how it just cascades down that waterfall. And by the time you reach the hospital, they're so far behind the 8 ball that they can't catch up. And so you can see how it very, very quickly leads to ARDS, leads to MODS, and then eventually leads to death. So a couple of tertiary subjects that's important to understand in this idea of sepsis is pathological cellular composition. So the fluid shifts, diffusion, that kind of stuff. And that's just what we're going to talk about real quick before the end. So fluid composition, the human body is primarily composed of water. Infants are 75% by mass water. So a huge portion of an infant is water, and adults are 50 to 60% water depending on pathology. So if they're super adenomous, obviously they're going to be a little bit more percentage water than a normal person. Fluid is always in flux through a variety of regulatory mechanisms to maintain appropriate concentrations throughout the various compartments of the body, right? Everything is always in a state of attempting to achieve homeostasis. The body is not stagnant, so things are shifting and moving all the time when you're just sitting still. Fluid is largely regulated through passive diffusion following the concentration gradients of osmotically active solutes. So diffusion versus osmosis. So what is the difference between osmosis and diffusion? Osmosis is the movement of solvent particles across a semi-permeable membrane from a dilute solution into a concentrated solution. This equalizes the concentration of the solutes. And diffusion is movement of the solute particles from an area of higher concentration to lower concentration. The overall effect is to equalize the concentrations on both sides of a medium. So essentially, this top picture is diffusion. So you're getting the little red dots that are moving from an area where it's super concentrated and into an area that it's not in order to create homeostasis. Osmosis is the movement of the water in order to create homeostasis between the two. So in that first beaker, you're seeing that there's a lot more space and a much less concentrated solution than on the right side of that first beaker. And then in the second beaker, the water has moved to the right side of the beaker in order to create the same concentration of the solution as the left side, even though it has a lot more solutes in it. So it's just moving, shifting the water. So it's attempting to create homeostasis with that concentration of the solution. So an example of osmosis in the body. So red blood cells swelling up when exposed to fresh water. Maybe you can think of like a plant taking up water. So like the roots taking up water so that they're getting an equal concentration gradient. That's kind of how like trees water themselves. Water on the ground. Examples of maybe some diffusion in a body or just in general, maybe like perfume filling up a whole room instead of a super concentrated area. Adding a drop of food coloring to water, you definitely see diffusion. They're related and they display similarities. So they both equalize the concentrations of two solutions, and both diffusion and osmosis are passive transport processes, meaning that they don't require energy in order to do this. And they both move from an area of higher concentration to an area of lower concentration. So you're not using ATP in order to do this. A huge difference between osmosis and diffusion is that both solvent and solute particles are free to move in diffusion, but when we talk about osmosis, only the solvent molecules, aka the water, can cross that membrane. So there's not a membrane in diffusion, and there's a semi-permeable membrane in osmosis. So there's a lot more osmosis in the body than there is diffusion. If you are talking about the beakers down below, if the solute particles can't cross the barrier, the only way to equalize the concentration of both sides of the membrane is for the solvent particles to move in, if that makes sense. So osmosis is only because diffusion can't happen because there's a semi-permeable membrane. So clinical significance of diffusion and osmosis. Fluid overload, that's an increase in extracellular fluids to third spaces, causing edema. This actually causes a decrease in effective fluid. If you think about it, you're not able to use that fluid around the body. A fluid shortage, decreased fluid in intracellular fluids, secondary to diarrhea, burns, vomiting, sweating, excessive breathing, pathological diabetes, excessive sodium. So if you have just too concentrated sodium, aren't reaching homeostasis, and you can't have osmosis from it. Hyponatremia can cause a state of intracellular fluid overload, putting the body in a state of dehydration and fluid overload. It's super strange, and it requires very careful fluid resuscitation by ICU level physicians. So essentially, you have to remember that the body is going to attempt to create homeostasis. So it's going to do diffusion, it's going to do osmosis, and sometimes that can be really detrimental because it pulls water out of the cells and into the extracellular space in order to create equal solvent to solute concentrations. And sometimes that's not what we need, i.e., like hyponatremia or something like that. Acid base balance. So I know this is probably really physiology heavy, just like the osmosis and diffusion. But an important property of blood is its degree of acidity or alkalinity. So when we're referring to acidity or acid, we are speaking about excessive hydrogen ions. So that's all that acid means or acidic means. So if you think about acidity or alkalinity of any solution, including blood, it's indicated on a pH scale. So the pH scale ranges from 0, so strongly acidic, to 14, strongly basic or alkalinic. A pH of 7.0 in the middle of this scale is neutral, but blood is normally slightly basic with a normal pH range from about 7.35 to 7.45. Usually the body maintains a pH of close to 7.40. Doctor evaluates a person's acid-base balance by measuring the pH and levels of carbon dioxide, an acid, and bicarbonate, a base, in the blood. So blood acidity increases when the level of acidic compounds in the body rises through maybe increased intake or production or decreased elimination. So if you can't get rid of that excess hydrogen, and level of basic alkaline compounds in the body falls through decreased increase or production or increased elimination. Blood alkalinity increases when the level of the acid in the body decreases or when the level of base increases. And obviously that makes more sense, right? So the body's balance between acidity and alkalinity is referred to as an acid-base balance. And this is a really broad, really huge subject. The blood's acid-base balance is precisely controlled because even a minor deviation from the normal range can really super affect many, many organs. The body uses different mechanisms to control the blood's acid base balance. These mechanisms come from the lungs, the kidneys, several buffer systems around the body. The lungs, this is a really big one, is the mechanism that the body uses to control pH, involves the release of carbon dioxide from the lungs. And that makes sense, right? So you're breathing off extra CO2. CO2 is mildly acidic with a waste product. It is a waste product of processing metabolism of oxygen and nutrients and is constantly produced, right? So we're always breathing out CO2. So we're always breathing out a little bit of acid, a little bit of extra hydrogen. The brain regulates the amount of carbon dioxide that is exhaled by controlling the speed or the depth of ventilation. So if we're a little bit acidic, we're going to start breathing faster in order to get rid of those extra hydrogen ions. The amount of carbon dioxide exhaled, consequently, the pH of the blood increases as breathing becomes faster and deeper. By adjusting the speed and depth of breathing, the brain and lungs are able to regulate the blood pH minute by minute. So if you see a very, very sick person who's breathing super fast, that's their brain attempting to balance it. So if you intubate them and then you're bagging them and you're slowing down that, you're kind of corrupting the body's natural way of balancing that acid base. The kidneys are able to affect blood pH by excreting excess acids or bases. The kidneys have some ability to alter the amount of acid or base that is excreted, but because the kidneys make these adjustments a lot slower than the lungs do, their compensation generally takes several days. So it's super slow. But buffer systems, this is just another mechanism for controlling blood pH. Using chemical buffer systems, which guard really against like big sudden shifts of acidity and alkalinity. Their pH buffer systems are combinations of the body's like own naturally occurring weak acids and weak bases. The weak acids and bases exist in pairs that are unbalanced under normal pH conditions. The pH buffer systems work chemically to minimize changes in the pH of a solution by adjusting the proportion of acid and base. So essentially, they're like little excess acid and bases that kind of roam around the body and make very, very minute changes. The most important pH buffer system in the blood involves carbonic acid and bicarbonate ions. So those kind of flow around the body and make small little adjustments here and there. Okay, so treatment of sepsis, treatment of SIRS, MODS, ARDS. Essentially, sepsis and septic shock are medical emergencies, and we recommend that treatment and resuscitation begin immediately. So that means that the minute that you come into contact with someone and they meet that QSOFA criteria, we need to start treating them. So we obviously can't identify whatever pathogen is causing it, right? We don't have a lab in the back of our ambulance. We don't have antibiotics most of the time in the back of our ambulance, but we can correct hypovolemia. So these patients need fluid. They need, because their vessels are vasodilating, remember we talked about that, and they have increased permeability, they're losing fluid at an excessive rate. So we need to give them fluid. A lot of the times, hospitals will give like 4, 5, 6 liters of fluid. And obviously their vessels are pretty leaky. They're pretty permeable because they have all those holes in their vessel walls. So a lot of these patients will get pretty edematous, but you have to give them fluid anyway, because otherwise their blood pressure is going to continue to drop. You're going to bring on that MODS a lot faster if you don't. Giving them a lot of oxygen. If they're to the point where they have low oxygen perfusion, then you're already behind the 8 ball. So you need to be giving them supplemental oxygen. If they are reaching the point of ARDS, they need to be ventilated so that their lungs can take a break. But really, when you come into contact with someone with sepsis in the field, you start 2 large bore IVs, your ALS partner will, you give them a lot of fluids, you work on their oxygen. If they have a super, super high temperature that's dangerous to the brain, you can give them some Tylenol in order to reduce it, and you get them to that hospital as fast as you can. When they get to the hospital, they locate the origin of infection and provide source control interventions as soon as possible, aka they run labs to determine what kind of infection they have. They give broad spectrum IV antibiotics. They give large amounts, 30 mils per kilogram of IV crystalloids, so fluids, during the first 3 hours of identification of sepsis related hyperperfusion. They target an initial MAP of 65. And if the fluids isn't getting your MAP above 65, then you need to use vasopressors. So that we definitely do use a lot of vasopressors, particularly like norepinephrine, in the field for patients that are very hypotensive secondary to sepsis. Yeah, norepinephrine, vasopressor of choice for sepsis related hypotension.
Question number 1. Which of the following is a typical trigger for sepsis? A. Hypoglycemia. B. Bacterial infections. C. Hypertension. Or D. Atrial fibrillation. The correct answer for this question is B. Bacterial infections. Bacterial infections are the most common cause for sepsis. Sepsis can also be caused by fungal, parasitic, or viral infections. The source of infection can be any number of places throughout the body for its presence. Question number 2. Which of the following is the first stage of sepsis? A. Systemic inflammatory response syndrome. B. Sepsis. C. Severe sepsis. Or D. Septic shock. The correct answer is A. Systemic inflammatory response syndrome. SIRS, or systemic inflammatory response system, is typically the first stage of sepsis. The second stage is known as sepsis itself. The third stage is severe sepsis. And the final and fourth phase is septic shock. Question number 3. Septic shock falls under which of the following large shock categories? A. Cardiogenic shock. B. Hypovolemic shock. C. Neurogenic shock. Or D. Distributive shock. The correct answer is D. Distributive shock. Distributive shock can be defined as hypoperfusion as a result of abnormal distribution of blood. In septic shock specifically, fluid is lost throughout blood vessels due to increased capillary permeability. Question number 4. Septic shock has to begin with blank, an infection that gets into the bloodstream and is transported throughout the body. A. Septicemia. B. Antibiotemia. C. Bulimia. Or D. Anemia. The correct answer is A. Septicemia. Septicemia, or sepsis, is an infection that gets in the bloodstream and then is transported all throughout the body as it creates a systemic infection as a result of it. Question number 5. Which 3 of the following are common symptoms of sepsis? A. Tachypnea. B. Hypertension. C. Tachycardia. D. Fever. And E. Hyperglycemia. The 3 correct answers should be A. Tachypnea, C. Tachycardia, and D. Fever. These 3 symptoms, as well as other symptoms that can include altered mental status and hypotension, are all common symptoms of sepsis. Hypertension and hyperglycemia can be seen throughout various stages of sepsis, but is an extremely rare situation. Question number 6. Which 3 of the following are part of the pre-hospital treatment for sepsis? A. Establishment of an IV. B. Fluid bolus. C. Dextrose 10%. D. High flow oxygen. And E. Furosemide. The correct answers for this question are A. Establishment of an IV. B. Fluid bolus. And D. High flow oxygen. The primary prehospital treatment for sepsis includes all of the following, which may be IV fluids, an establishment in an IV, high flow oxygen, vasopressors, and antibiotics. Question number 7. Which vasoconstrictor should be used if your pediatric patient in septic shock has not responded to fluid resuscitation and is still hypotensive? A. Atropine, B. Vasopressin, C. Norepinephrine, or D. Dopamine? The correct answer is C. Norepinephrine. Norepinephrine should be used if your pediatric patient is in septic shock and has not responded to fluid resuscitation and is still hypotensive, as seen in this question. It acts as an alpha adrenergic receptors to cause significant vasoconstriction throughout the blood vessels in the body. Question number 8. You have a 67-year-old female patient with a urinary tract infection. She is febrile, tachycardic, and hypotensive. The patient's symptoms are most consistent with which of the following conditions? A. Diabetic ketoacidosis, B. Sepsis, C. End-stage renal disease, or D. Congestive heart failure? The correct answer for this question is B. Sepsis. Just as we've been discussing, sepsis can be one of the causes for all the following symptoms in addition to altered mental status. Because of altered mental status being a common symptom with sepsis and a variety of other conditions, it's good for providers to do a thorough assessment and to rule out any other conditions that could be present. The following symptoms seen with this patient, including fever, tachycardia, and hypotension, are all common symptoms of sepsis. Question number 9. You are called to a care home for an unknown medical issue. Your patient is a 62-year-old male with type 2 diabetes. He is non-ambulatory and weighs 400 pounds. The patient's lower extremities appear red, swollen, and are oozing clear fluid. The patient moans upon palpation of his lower extremities. His response is to painful stimuli, and he feels very warm to the touch. What is your differential diagnosis? A. Eczema, B. Dermatitis, C. Deep vein thrombosis, or D. Cellulitis? The correct answer for this question is D. Cellulitis. Cellulitis often presents in the same manner as deep vein thrombosis, but the altered mental status and possible fever should concern. Cellulitis often presents in the same manner as deep vein thrombosis, but the altered mental status and possible fever should cause you to consider the presence of cellulitis. It's good to remember that cellulitis can also result in infections, which can lead to a patient developing sepsis. Question number 10. You have been dispatched to an assisted living facility. Your patient is an 82-year-old female who is running a temperature per staff. She has been ill for the last 2 weeks and seems to be getting worse, according to caregivers. The patient has no history of urinary tract infections, but did have pneumonia about a month ago. She is incoherent and continuously mumbles throughout the call. Your patient obtains the following vital signs: blood pressure 112/74, heart rate 110, temperature 101.9 Fahrenheit, SpO2 levels 94% on room air. Which phase of septic shock is this patient in? A. Hyperthermic phase, B. Hyperdynamic phase, C. Hypothermic phase, or D. Hypodynamic phase? The correct answer is B. Hyperdynamic phase. The hyperdynamic phase occurs in the early stages of septic shock. The cardiovascular system is still attempting to compensate by increasing cardiac output, but the blood vessels continue to dilate. The heart rate and body temperature are typically elevated during this phase, as seen in this question. The hyperdynamic phase was previously referred to as warm shock.